Welcome back to the class of Analysis of the Facial Beauty. I'm Dr. Strategy. In the last two sessions, we have discussed our powerful tool, cephalometric analysis. Today, we will cover the practical implementation of the facial analysis based on the facial type, proportion, and symmetry. Okay, there are no rules in facial aesthetic evaluation. All the analyses described serve as a guidelines to aid the clinician in understanding the structural and morphological characteristics of the craniofacial complex of each patient. Aesthetic guidelines may be based on the classical, Renaissance, or neoclassical canons of the proportion, and modern anthropometric and cephalometric data from the population norms. Finally, they are based on the result of the attractiveness perception studies. To be able to recognize the abnormal craniofacial morphology, the clinician must have a thorough knowledge of normative standards of comparison, which may be used as a frames of reference. The trained clinicians will use all the above data and selected parts of the relevant analysis as a diagnostic guide. Nevertheless, the diagnosing clinician must learn to apply the acquired information to each patient. In other words, the final analysis for each patient is individualized. Generally, the clinical inspection has a perspective of process and the education of the eye as well. The term clinical inspection refers to the accurate, thorough, and systematic observation of a patient with a trained eye. The purpose of clinical inspection is observation. This is to extract the salient information from thorough observation of the patient in repose and in animation. Superficial observation inevitably leads to the incorrect diagnosis. Palpation. The manual palpation of the craniofacial region in order to help relate the surface anatomy to the deeper structures, a number of bony prominences and thicknesses of the overlying soft tissue may be palpated. And finally, the analysis of diagnostic records. In the management of facial deformities, clinical diagnosis is essential descriptive diagnosis. In other words, it requires the ability to accurately describe the morphological features and structural relationships of the craniofacial complex. This ability requires a trained eye. Artists refer to a training in observation as the education of the eye. Such ability may only be gained from the keen observation and analysis of a large number of patients and their diagnostic records until the clinician gains the ability to discern characteristics that are not necessarily obvious to the untrained eye. Leonardo da Vinci termed this concept saper vedere, or knowing how to see. A layperson will look at a beautiful building and may see that it is beautiful, but they will not necessarily be able to explain why it appears beautiful to them. They will not see the building in the same way as a professional architect. The architect will know what to look for, that is to say, saper vedere. Training in observation follows the same principles as training in any activity. There is no substitute for extensive practice. The clinician must become obsessed with observation. Effective clinical observation also requires a strong theoretical background, for only by being familiar with normal craniofacial anatomy and aesthetic principles will the clinicians notice something as unusual. The human face is one integrated whole, yet consists of a myriad component parts. Training in observation is thereby the essential prerequisite to accurate clinical diagnosis. The clinical evaluation of the craniofacial complex essentially consists of the three consecutive stages. The first is the initial qualitative evaluation, and then the quantitative analysis will be performed. Finally, subsequent qualitative evaluation should be considered. The initial qualitative evaluation involves the observation of the patient and is required to acquire preliminary data, are but somewhat subjective. The quantitative analysis involves anthropometric and cephalometric data collection and analysis. It must be systematic, accurate, and thorough. The subsequent qualitative evaluation involves observation for the patient in light of the previous findings. It must be assiduous and reflective. The clinician must synthesize the data from the initial qualitative evaluation and the quantitative analysis. The purpose is to see whether the results of the quantitative analysis corroborate the initial qualitative evaluation. If they do, the descriptive clinical diagnosis may be made. If they do not, the process must be started again in order to find out where the discrepancy has arisen. Regarding the qualitative evaluation, the viewing position of the patient and clinician and the viewing distance between the patient and clinician are important considerations in the initial qualitative facial evaluation. When it comes to the viewing position, a practical viewing position is required for the initial qualitative facial evaluation. The patient must be examined in natural head position, and their head should be level with that of the clinician. Ideally, the patient and clinician may stand facing one another. However, in situations where there is a significant height difference between the patient and clinician, they may be seated on adjustable seats with their head level, taking care to maintain the patient head in natural head position. An initial viewing distance between the patient and clinician of approximately 1 meter is recommended. The next is the quantitative evaluation and analysis. The quantitative evaluation involves the thorough craniofacial anthropometric and cephalometric evaluation and the analysis of other diagnostic records where necessary. The purpose is to first is obtain objective data, that is, collection of factual data that is free from subjective opinion, for example, linear and angular craniofacial measurements. The second, analysis of the objective data. In other words, proportional analysis, bilateral symmetry analysis, and comparison of measurement to age, sex, and ethnicity-specific normative values. The clinical data collected from the qualitative and quantitative evaluation may be used to assess the following. Number 1. Define the normal. Define which craniofacial structures are normal size and morphology and in the correct relative position. Number 2. Define the abnormal. Define which craniofacial structures are of abnormal size and or morphology and in an incorrect relative position. Number 3. Relate the abnormal to the normal. Identify which analysis may be used to relate the structures identified in the incorrect relationship to those in the correct relationship. Number 4. Check findings. Identify alternative analyses that may be used to check the craniofacial relationships. Regarding the diagnostic process, it is notable that in the management of the dentofacial and craniofacial deformities, clinical diagnosis is not one's only event but is a continuing process. The patients must be re-evaluated throughout the treatment. This is particularly important in the management of patients requiring orthodontic surgery as considerable facial changes occur during the pre-surgical orthodontic phase. In addition, changes due to growth, soft tissue maturation, and subsequent aging must all be taken into consideration. Finally, the clinical evaluation can be said as the sequence. Thorough clinical evaluation required for accurate clinical diagnosis should be systematic. A methodological approach to clinical evaluation permits the sequential progress through a number of successive stages required to collect and analyze the relevant data. In the following, we will discuss the overall clinical evaluation of facial type, facial proportion, and bilateral symmetry. Following these stages, the clinician will have identified the facial region at fault. Okay, moving on to the next section, we will discuss about the facial type. For this purpose, we frequently use the cephalic index. The cephalic index, or index cephalicus, is a numerical expression of the ratio between the head width by parietal diameter and head length fronto-occipital diameter of a living person. The cranial index, introduced by the Swedish anatomist Anders Retius in 1842, is the equivalent of the cephalic index in a dry skull. It is used in craniometry to classify the skull types. The cephalic index CI is calculated by the formula maximum head width soft tissue urion to urion is divided by the maximum head length soft tissue glabella to ophistocranion is multiplied by the 100, where soft tissue urion is the most prominent lateral soft tissue point overlying each side of skull in the area of the parietal and temporal bones. Soft tissue glabella is the most prominent midline point between the eyebrows. It is identical in position to the bony glabella on the frontal bone. And ophistocranion is the point situated in the occipital region of the head, most distant from the glabella. It is the most posterior point of the line of the greatest head length. The cephalic index is used in anthropometry to classify head types as dolichocephalic, mesocephalic, and brachycephalic. Dolichocephalic head type is horizontally long and transversely relatively narrow. Mesocephalic head type is the average, lying in between the two extremes. The brachycephalic head type is horizontally shorter and transversely wider. Obviously, there is an ethnic difference in cephalic index. The highest cephalic index value occur in the Chinese and the lowest values in African Americans. The larger index values of the Chinese differ significantly from those of white or blacks. And there is also ethnic differences in white individuals. A comparison of the cephalic index of the three ethnic groups was undertaken: North American Caucasian, Northern European, such as German, and Eastern European, such as Czechs. The index values indicated a mesocephalic head type for both sexes of North American Caucasians and Northern Europeans, and brachycephalic head type for the Eastern Europeans. The next index is the head circumference. The head circumference is measured in horizontal plane around the head through the glabella and ophistocranion. However, it may be measured across the ophidian. The ophidian point is abbreviated ON, and in the mid-sagittal plane of a line tangent to the upper limits of the eyebrows, rather than the glabella, in order to eliminate the effect of the development of the frontal sinuses and superior orbital rims on head circumferences. In head circumferences, there is also ethnic differences. African Americans have the largest and the Chinese have the smallest head circumference for both sexes. The head circumference is slightly larger for blacks than for whites in both sexes. The next is the facial type. From the frontal view, norma frontalis. The initial step in facial analysis involves the examination of the face in frontal view in order to assess the overall facial shape. The variety of facial shape is almost limitless. However, a simple assessment will allow an overall categorization of the basic facial shape. The basic facial shape in frontal view may be any combination of the following. Overall facial shape can be classified as round, square, or triangular. Vertical facial height can be classified as reduced, normal, or increased. Transverse facial width classified as broad or wide, normal, or narrow. Variations in facial height and width result in an innumerable variety of the three basic facial shapes. For example, an oval facial type is a combination of an oval or round face combined with increased vertical facial height and or reduced facial widths. Facial height to width ratio or proportion. The relationship of the vertical facial height to facial width is an important indicator of the overall facial shape. There are three methods of evaluating the vertical facial height to width proportion. These may be represented as proportions, percentages, or indices. The first one is the craniofacial height, vertex to menton to facial width. Zaijian to Zaijian. The craniofacial height is measured from the vertex, the highest point of the head, with the subject in natural head position, to the menton, and by zygomatic facial width measured from the most lateral point of the soft tissue overlying the zygomatic arch. That means the soft tissue Zaijian is approximately 60% of the vertical craniofacial height. The second is the physiognomical facial height, Trichion to menton, to facial width, Zaijian to Zaijian. Bizygomatic facial width is approximately 70 to 75 of the vertical facial height. In addition, bitemporal width measured from the most lateral point of each side of the forehead is 80 to 85% of the bizygomatic width. Bigonial width measured from the soft tissue overlying the most lateral point of each mandibular angle. Soft tissue gonion is usually 70 to 75% of the bizygomatic width. Finally, the morphological facial height or face height, Zaijian to menton to facial width, Zaijian to Zaijian. This is otherwise known as the facial index. The facial index, index facialis, or index of the morphological face height, is numerical expression of the ratio between the facial height, that is Zaijian to menton, and the bizygomatic facial width, Zaijian to Zaijian, of living person. The facial index, Fi, is calculated by the formula facial height, soft tissue Zaijian to soft tissue menton, is divided by the bizygomatic facial width. And this number is multiplied by the 100. The facial index is used in anthropometry to classify face as euryprosopic, mesoprosopic, or leptoprosopic. Euryprosopic face type is transversely wider and vertically relatively reduced in height. The mesoprosopic face type is the average lying between the two extremes. The leptoprosopic face type is vertically relatively tall and transversely narrow. The next is the facial type in profile view, norma lateralis. Facial divergence. The term facial divergence was introduced by the orthodontist anthropologist Milo Hellman, although the concept had been described by the Albrecht Dürer. It is essentially a description of the slope or inclination of the face in the sagittal plane. It is determined by the sagittal proportion, subtissue pogonion, and subnasal relative to vertical line dropped from glabella, soft tissue glabella, with the subject head in natural head position. The factor that discriminates and distinguishes a facial divergence from profile convexity or concavity is the sagittal position of subnasal relative to soft tissue glabella to soft tissue pogonion line. In order for the face to diverge anteriorly and posteriorly, yet not to exhibit signs of convexity or concavity, subnasal must be on or nearly on the soft tissue glabella to soft tissue pogonion line. That is, the upper facial plane and the lower facial plane are in straight line but diverge anteriorly or posteriorly. Posterior divergence. The vertical soft tissue glabella, subnasal, and soft tissue pogonion line slopes posteriorly with pogonion posterior relative to glabella in the sagittal plane. This facial pattern is common to individuals of Northern European ancestry. Neutral divergence. The vertical soft tissue glabella subnasal soft tissue Pagonian line is parallel to the true vertical line, with Pagonian in approximately the same position as glabella in the sagittal plane. Finally, the anterior divergence. The vertical soft tissue glabella and subnasal and soft tissue Pagonian line slopes anteriorly and Pagonian anterior relative to glabella in the sagittal plane. This facial pattern is common to individuals of African ancestry. Anthropometric data from North American Caucasian male and females with untreated class 1 dental occlusion describing normal facial divergence and a range of variability has been published. Mean values of the facial divergence are negative, with the face being slightly posteriorly divergent. Anterior divergence does not occur until 2 standard deviations from the mean. Facial divergence is essentially an ethnic variation in facial profile form, with a straight profile, that is, no excessive profile convexity or concavity. Anterior or posterior facial divergence is compatible with normal maxillomandibular and dental occlusal relationships. The next is the sagittal facial profile contour. The contour of the facial profile may be described as convex, straight, or concave. This concept was described by the Alberti Dürer. With the patient in natural head position, the overall contour of the facial profile may be described by the relationship between two lines. The upper facial plane, connecting soft tissue glabella to subnasal, and the lower facial profile, connecting subnasal to the soft tissue Pagonian. In a straight profile, these two lines form a nearly straight line. Such a facial profile is termed orthogonalic. An angle between these two lines indicates a facial profile convexity, Pagonian behind relative to subnasal in the sagittal plane, or facial profile concavity, Pagonian ahead of the relative to subnasal in the sagittal plane. A convex profile indicates a skeletal class 2 jaw relationships and or sagittal chin deficiency, and a concave profile indicates a skeletal class 3 jaw relationship and or sagittal chin excess. However, profile convexity or concavity does not always self-indicate whether the maxilla or mandible is at fault. More specifically, there is angulofacial profile convexity. As an alternative term, there is facial contour angle. Ligon and Burston describe the angulofacial convexity for the soft tissue profile. It is formed by the two intersecting lines, the upper facial plane and the lower facial plane. The mean value is estimated to be 12 degree plus minus 4 degree. An increase in the angle in a clockwise direction is positive, anti-clockwise is negative. A high positive value suggests the facial profile convexity and a class 2 skeletal jaw relationships. On the other hand, a smaller positive value or negative value suggests facial profile concavity and a class 3 skeletal jaw relationship. However, the value of this angle does not reveal whether the maxilla or mandible is responsible for sagittal jaw discrepancy. Another parameter I will introduce to you is the angle of facial profile convexity. Downs describe the angle of convexity formed by the intersection of line nasient to point A and line point A to Pagonian. Superior extension of the apagonian line forms an angle with an NA line. If behind the NA line, the angle is read as positive, indicating a class 2 convex skeletal profile. A negative angle of convexity indicates a class 3 concave skeletal profile. Downs provided a range of values from minus 8.5 degree to 10 degree with a mean of 0 degree. Again, as with facial contour angle, the angle of convexity does not determine the localization of the deformity to the maxilla or mandible chin. The next is the facial angle. The facial angle indicates the relative sagittal prominence of soft tissue pogonion. It is formed by the intersection of a true horizontal plane or Frankfurt horizontal plane with a facial vertical plane, soft tissue Daisian to soft tissue pogonion. The angle should be 90 to 92 degree. A greater angle indicates prominence of the soft tissue pogonion. On the other hand, an angle less than 90 degrees indicates a retrusion of soft tissue pogonion. The soft tissue facial angle does not of itself determine the etiology of the sagittal position of the soft tissue pogonion, which may be due to one or a combination of follows. Number 1. The sagittal position of the mandible, retrognathic or prognathic. Number 2. The size of the mandible, micrognathic or macrognathic. The sagittal projection of the chin, retrogenic or progenic. The thickness of the soft tissue chin pad, reduced or increased. Consequently, the facial angle must be used in conjunction with other measurements on analysis. In addition, when constructing the facial vertical line, soft tissue nasion to soft tissue pogonion, if the sagittal position of nasion is not acceptable, it may be adjusted to a more ideal position. The alternative is to use soft tissue glabella rather than nasion. The next is the facial angle. Downs described the facial angle as the inferior inside angle in which the facial line and to pogonion intersects the Frankfurt horizontal plane. Downs found a mean value of 88 degree with a range of 82 to 95 degree. It indicates the relative sagittal position of the mandible or chin to the upper face. Cranial base angle. The relationship of the anterior to the posterior cranial base is of particular importance in the diagnosis of the facial profile contour. This relationship depends on the extent of growth at the sphenoethmoidal and sphenooccipital synchondroses. The cranial base angle or saddle angle represents the orientation of the anterior cranial base relative to the posterior cranial base. The average adult values for the angle NS Bayesian are in male 109 degree plus minus 5 degree, in female 132 degree plus minus 4 degree. As such, the cranial base angle is an important determinant of craniofacial form as it influences the sagittal position of the face relative to the neurocranium and the sagittal prominence of the mandible relative to maxilla. A significantly increased cranial base angle contributes to a skeletal class 2 jaw relationship, whereas the reduced cranial base angle contributes to a skeletal class 3 jaw relationship. If Bayesian is difficult to identify on a lateral cephalometric radiograph, articulaire may be used instead. That is, the posterior cranial base is drawn between sella and articulaire. The next item is the anterior cranial base length. The anterior cranial base length, measured from sella to nasion, may also influence the jaw relationship. For example, increased anterior cranial base length may lead to a class 2 jaw relationship with the maxilla ahead of the mandible in the sagittal plane, whereas the reduced cranial base length may lead to a class 3 jaw relationship with the maxilla behind the mandible in the sagittal plane. The next is a parasagittal facial profile contour. An additional and extremely important consideration is the description of the parasagittal profile. It is necessary to evaluate the sagittal relationship of the soft tissue from the infraorbital area to paranasal area to the parasymphysial area. For example, maxillary hypoplasia may lead to a lack of bony support and flattening in the infraorbital region and paranasal hollowing. With a normal parasymphysial area, this will lead to an appearance of the concave parasagittal profile. Moving on to the vertical facial profile form. The directional pattern of the facial growth has a significant effect on facial profile form. Deviation from the normal pattern of jaw growth may be in predominantly vertical or horizontal direction. First, we will discuss about the vertical facial growth pattern and hypodivergent facial type. Alternative terms are hyperdivergent facial growth pattern, or long face deformity or long face syndrome. If hyperdivergent growth is the primary etiology to an anterior open bite, the term skeletal open bite or aportonathia may be used. The maxilla rotates downward and backward, as does the mandible during growth. This leads to a reduced sagittal projection of the chin. Such a vertical facial growth pattern will tend to be associated with a posterior pattern of the mandibular growth rotation. On the other hand, there is a horizontal facial growth pattern and hypodivergent facial type. Alternative terms are hypodivergent facial growth pattern, which is referred to the almost parallel orientation of the maxillary, occlusal, and mandibular planes in relation to each other. Such a pattern of growth leads to a hypodivergent facial type, alternatively termed as a low-angle patient, which is referred to the reduced mandibular plane angle, or short face deformity or short face syndrome. If the hypodivergent growth is the primary etiology to a deep incisor overbite, the term skeletal deep bite may be used. An element of the vertical maxillary deficiency often coincides with mild mandibular retrognathia, leading to a reduced lower anterior facial height, a reduced mandibular plane angle, and mandibular oval closure. Such hypodivergent facial growth pattern will tend to be associated with an anterior pattern of mandibular growth rotation. A number of clinical and cephalometric parameters may be evaluated in order to analyze vertical facial profile form. The first is the mandibular plane angle. This is formed by the angle between the mandibular plane tangent to the inferior border of the mandible and the true horizontal or Frankfurt horizontal plane. The advantage of this variable is that it may be measured clinically. The mandibular plane may be assessed clinically by placing a finger or a dental mirror handle along the inferior lateral border of the mandible. This angle may be assessed both clinically and cephalometrically. The following value for the Frankfurt horizontal and mandibular plane angle FMPA have been reported. From Downs, the average is the 22 degree. From Tweed, 25 degree plus minus 3 degree. Tweed reported this angle to be useful indicator of the direction of the lower facial growth. According to the Ricketts, 26 degree plus minus 4 degree is the norm. The next is the mandibular plane angle by cephalometric analysis. This indicates the difference between the anterior and posterior facial height. The mandibular plane is drawn between gonion and menton, or may be drawn as a tangent to the inferior border of the mandible. SM plane to mandibular plane angle. Steiner related the mandibular plane to the anterior cranial base, describing the SN to the mandibular plane angle, giving a mean value of the 32 degree. Maxillary mandibular plane angle, MMPA. The mandibular plane may also be related to the maxillary or palatal plane. The size of this angle is determined by the ratio of anterior to posterior intermaxillary height, providing a measure of divergence of the intermaxillary space anteriorly. Variations are usually due to the inclination of the mandibular plane, but may also be due to the inclination of the maxillary plane. The suggested mean value of approximately 26 degree plus minus 5 degree has been verified. Corneal angle. This is a measure of the angle formed between the slope of the posterior border of the mandibular ramus and the mandibular plane. It helps to describe the form of the mandible, in particular the relationship between the ramus and the body. It is highly correlated with the mandibular plane angle. An increased corneal angle is associated with posterior mandibular growth rotation, and a reduced corneal angle is associated with anterior or forward mandibular growth rotation. There are convergence of horizontal facial plane concept in Sassoni analysis. An extremely useful method of evaluating vertical facial relationships is to analyze the relative orientation of the horizontal planes of face and their posterior region of convergence. The next is the facial height to horizontal facial depth ratio in cephalometric analysis. The orthodontist Hans Bimmler introduced the suborbital facial index relating suborbital facial height to horizontal lower facial depth in profile view using the lateral cephalometric radiograph. The horizontal reference line is the Frankfurt plane. Anterior and posterior limits to the face are determined by dropping verticals perpendicular to the Frankfurt horizontal plane through maxillary A point and the condyle midpoint. The posterior limit of the maxilla may be determined by dropping a perpendicular from the pterygomaxillary fissure. The index is established by measuring the anterior suborbital facial height and transferring the measurement horizontally to the Frankfurt horizontal plane. This is the horizontal facial depth. The point of intersection gives the facial type as a deep face, medium face, and narrow face. In case of deep face, the intersection is anterior to the point cone, vertical and horizontal facial depth is greater than the facial height. In medium face, the intersection is between the point cone, CON, and the clivus. Finally, in narrow face, the intersection is posterior to the clivus and facial height is greater than the horizontal facial depths. And there is a parameter named as a facial growth axis in cephalometric analysis. Ricketts described the facial axis as the posterior angle formed by the intersection of the Bayesian-Nagian plane and the PT and GN line. It describes the direction of growth of the mandible or chin and is said to remain relatively constant with ages in patients with a normal growth pattern. The norm is known as 90 degrees plus minus 3 degrees. Y-axis. Downs describe the y-axis or y-growth axis as the anterior angle formed by the intersection of the Sella-Nathan line with the Frankfurt horizontal plane. It describes the position of the chin in relation to the upper face. The norm is known to be 59.4 degrees, with ranges of 53 to 66 degrees. Okay, today we have discussed the diagnosis process and briefly talk about the facial type, especially focusing on the issues from the perspective of frontal, sagittal, and vertical. In the next session, we will discuss more in detail the curvilinear relationships and the facial proportion. Thank you for watching and stay tuned.